Hello and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Nathan Price, a pediatric infectious diseases specialist at Banner University Medical Center, Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. With Dr. Scott Olson, I'm the Arizona AAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of May 19th, 2025. So let's get to our questions. Question 1. If a patient is fully vaccinated, having received 2 doses of MMR but may have measles, what is the best way to diagnose them? Are serologies helpful? This is an excellent question and one that many of us have been dealing with since there's a fair bit of measles in the U.S. We know that it's only a matter of time before we end up having a case of measles in Arizona, but up to this point I'm not aware of any cases that have been diagnosed in Arizona this year. That being said, there are a lot of things that look like the measles, and so the question will come up fairly often in the coming weeks and months. Could this be a case of the measles? So, measles virus is a virus that can be shed in respiratory secretions in the urine. It can also be detected in the blood. The virus is most likely to be detected within the first few days of the onset of rash, but it can be present up to 10 to 14 days after the onset of rash. For PCR testing, a respiratory specimen is preferred, and you can use sources such as a swab from the buccal mucosa, nasopharyngeal, or throat swabs. The swab should be placed in viral transport media, Hanks solution, or universal transport media. Generally, it's preferred to do the swab within 3 days of onset of rash, but it can be done up to 10 days within onset of rash. When it comes to serology, it can be tricky to interpret the results in the setting of prior vaccination. We know that IgM tends to show up as early as 3 days after rash onset, and it can persist in circulation for weeks to months afterward. An IgM response can be seen after infection, but it can also be seen in the setting of prior vaccination. False positives can occur in the setting of other rash-producing viruses and other diseases such as autoimmune diseases. IgM can also be positive for a period of time after vaccination. And of course, false negatives can occur as well. IgM testing is recommended in a suspect case 3 days or later after the onset of rash. IgG can be present from prior vaccination or the result of infection. When it comes to serology and prior vaccination, remember about 7% of people don't respond to the first vaccination, and about 3% of people don't respond to the second vaccine dose. Serologic testing is usually done at a commercial lab, and PCR testing is usually done at the CDC. If you suspect that someone has the measles, the first thing to do is to properly isolate the patient. Put a simple mask on the patient right away, and put them in a negative pressure room if you have one at your facility. If you don't have a negative pressure room, then put them in a room that's as far away from other patients as possible. Ideally, if you know that a patient is coming in with a complaint of a rash suspicious for measles, you can meet them outside the facility and put the mask on them and then bring them immediately into a room. That way you don't have them in the waiting room exposing other people to the infection. Healthcare workers should wear an N95 mask or use an approved respirator when they're evaluating the patient. If you have an infection prevention team at your facility, you should notify them right away so they can help you as well. Then you should notify your local health department, and this part's really important because they can help coordinate specimen collection and processing for PCR testing at the CDC. They can also help advise isolation of the patient at home if they go home, and also can help with contact tracing. Okay, so let's go to the next question. Question 2. Can you speak about why HIV infection is associated with significant increased risk of hospitalization in Mpox cases? Another great question. Let's talk about Mpox first. Mpox is the disease caused by the monkeypox virus. It's an orthopox virus that's related to vaccinia and smallpox. It's transmitted by close contact with lesions and infected body fluids, and the risk of transmission through respiratory route is thought to be low. The prodrome may include fever and adenopathy, malaise, sore throat, headache, things that we associate with any old type of viral disease. Shortly after the prodrome, a rash develops, and it starts as macules that then progress to papules, followed by vesicles and pustules. These lesions can be quite painful and can take 2 to 4 weeks to heal. Most cases are self-limiting, but in some patients, severe manifestations can occur such as ocular disease, encephalitis, pneumonia, and severe skin disease. And of course, you can get bacterial superinfections in certain situations. We know that immune-compromised patients tend to have a higher risk of more severe mpox disease. There's an antiviral called tecovirimat that has activity against the virus, and it can be used in certain situations. There's also a replication-incompetent live virus vaccine that's available that can be used for pre- or post-exposure prophylaxis in high-risk individuals, including immunocompetent and immunocompromised individuals. So let's talk a little bit about HIV. We know that HIV can cause immune suppression. One of the early things that was learned about HIV is that uncontrolled viral replication led to depression of CD4 counts, and then that led to the development of opportunistic infection and death in patients with uncontrolled HIV. But HIV also affects many other parts of the immune system besides just the CD4 count. With the advent of antiretroviral therapy, we were able to treat the patient, get the viral replication under control to where it became undetectable, and then the CD4 count would usually be restored. But in some patients, it doesn't return to pre-infection levels. And there's also data that mucosal CD4 counts will take years to get back to normal, even though the circulating CD4 counts are normal. We also know that the HIV virus can cause ongoing inflammation in the body, and that can even occur when the virus is undetectable with antiretroviral therapy. So even though a patient has well-controlled HIV and normal CD4 counts and is generally thought to be not immunocompromised, there may be a subtle unrecognized effect on the immune system. When looking at the data with mpox and HIV, there's quite a bit of heterogeneity in the data and the studies. And there still aren't a lot of studies out there. Recent meta-analysis suggested that there is a higher risk of mpox severity in patients who have HIV infection. Many of those studies showed that there was the higher risk with a low CD4 count and or a higher viral load. But some of the studies suggested that there was a modest increase risk of severe mpox disease even when the patient had a normal CD4 count and undetectable viral load. So we don't really know for sure why that is occurring. But again, maybe there is still some degree of subtle immune suppression that's happening in the setting of HIV infection. People continue to look at this, so I'm sure there's more to come in the future. Okay, let's go to the next question. Question 3. With GSK seeking FDA approval for gepotidacin, what makes it a good alternative to first-line therapy for gonorrhea? Another great question. Gepotidacin, whose brand name is Blue Gepa, is a new class of antibiotic. It's a triaza-acinapthyline antibiotic. It inhibits DNA gyrase and topoisomerase, leading to multiple gyrase-mediated single-strand breaks in the DNA. It's bactericidal and seems to have a low rate of development of resistance, and for the most part retains in vitro activity against quinolone-resistant bacteria that also target the DNA gyrase and topoisomerase. It has a very broad spectrum of in vitro activity against bacteria, including gram-positives such as MRSA, gram-negatives including gonorrhea, and some anaerobes. It's formulated as an oral tablet and has been FDA approved for the treatment of female, adult, and pediatric patients 12 years and older with uncomplicated urinary tract infections caused by certain susceptible bacteria. In clinical trials, side effects were similar to other antibiotics, with the most common effects being related to GI complaints. This year, a clinical trial using gepotidacin to treat uncomplicated gonorrhea was published in The Lancet, and it showed non-inferiority compared to ceftriaxone and azithromycin. And the company will likely use this and other data to apply for FDA approval for the treatment of gonorrhea. So this is really important because there is increasing drug-resistant gonorrhea disease in the U.S. and the rest of the world, and there are very few oral options available to treat gonorrhea. So I think it'll be really nice to have an additional antibiotic in our treatment kit for combating gonorrhea disease. If it's approved, we'll have to see what the recommendations end up being for the use of treatment for gonorrhea. I think cost will likely be an early factor as far as availability goes to our patients, but since it has such a broad spectrum of activity, it may be prudent to reserve it for treatment of resistant organisms, since overuse may lead to the development of additional resistance. It also may have a higher risk of developing C. diff, but again, we'll have to see as time goes on. Okay, next question, question 4, and this starts out with a quote. It says, "Not only have vaccination rates for measles, mumps, and rubella fallen, but federal data shows that So have those for pertussis, diphtheria, tetanus, hepatitis B, and polio, end quote, from ProPublica. What would you say are the most helpful strategies pediatricians can adopt to increase patient vaccination rates during times of vaccine hesitancy? Are there any patient-friendly resources we can share in our clinics? Another excellent question. So as mentioned in the quote, we know that vaccine rates are decreasing. And in Arizona during the 2023-2024 school year, the rate of MMR vaccination for kindergartners was 89.3%. They saw similar numbers for vaccination rate for DTaP and polio. And we know that in Arizona, the trend has been downward over the last few years with a decrease of anywhere from 0.5 percentage point to 1 to 2 percentage points depending on the year that's been studied. And ideally, we would like to have a coverage rate of 95% in order to prevent community outbreaks. So you can see that we have a lot of work to do here. When it comes to dealing with vaccine hesitancy, it's important to remember that no one size fits all. And that's because there's a whole host of reasons why people worry about vaccines. On one end of the spectrum, it could be something as simple as a family or a patient not having the right information. On the other hand, it could be something difficult, like a distrust in certain institutions or experts or authority. The good news is that most people still value the recommendation of a trusted medical provider when it comes to decisions on vaccines. So it is our responsibility to make sure that patients and their families have the best information available so they can make the best decisions for themselves. And of course, communication is key. And evidence shows that for improving vaccination rates, presumptive communication, so for example, saying something to the effect of "we are going to," is more effective than participatory communication. For example, saying something to the effect of "would you like to?" Again, one size doesn't fit all, and this may really work best for those that just need a little nudge in the right direction. Motivational interviewing can also be helpful in understanding the situation and finding common ground to move forward. And there are many resources available to help someone learn and develop motivational interviewing skills. In all of this, it's really important to listen in a non-judgmental fashion and validate that the person has a concern. It's also really important to communicate that you understand that they love their child and are seeking to do what's best. As you listen, you can better understand what the concerns are and then ask additional questions to better clarify the situation. As I mentioned, some concerns will be related to misinformation or a simple lack of understanding, and you can discuss that and help overcome that quite quickly in certain situations. Some concerns may be related to value systems that you need to better understand in order to address the root of the problem. Remember that this can take time. It may take time during that visit, and it may take time after the visit and may require multiple discussions over time. When it comes to resources for providers and families, there are a lot of options out there. The CDC still has a lot of good information about vaccines, including what the vaccine components are, how vaccines are chosen, and what the safety of efficacy in vaccines are. The AAP also has good information about how to talk to patients and parents who are hesitant to vaccinate. Immunize.org is a nice resource. It has lots of information for providers and has a lot of handouts for families as well. And I also like vaccinateyourfamily.org. It has a nice website with lots of good information for families and has some really nice family-friendly videos that can really explain things about vaccines. I recommend that you explore on your own and see what works best for you and your patients. Well, that about does it for this episode of ID Talk. Thank you again for listening. Arizona AAP members can submit questions for future episodes to id@azaap.org. Arizona AAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services, the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thank you for all that you do. We'll see you next time at the next ID Talk podcast.